here. My name is Lisa Yagi. I'm your moderator. So we have someone from Metro Geriatrics, the owner, pharmacist from Hy-Vee, and the local long-term ombudsman, and that's from Polk County. So I will have them turn it over and we'll have them talk about 1 to 2 minutes on their area of expertise and their name and what brought them to where they're at.
Hello. Good morning. My name is Kevin Babb. I'm a registered nurse. I'm one of the founders of a company called Metro Geriatrics. I found that with Dr. Hiley and Dr. Robert Connor. We now serve about 160 communities in Iowa and Nebraska, and we have about 45 providers. That includes physicians, 5 physicians, and then the rest are advanced practitioners, nurse practitioners, or PAs. We provide wound care, primary care, psychiatric services, and podiatry. That's part of our package for patients or residents who are in a home like Copper Shore. That's one of our bigger customers. And we provide that care for folks that are in independent living, in assisted living, and of course in long-term care, and then skilled care if they get to that place. So very happy to be here today. I have to disclose that Mary's daughter works for me.
Okay, my name is Jeff Diamond. I work for Hy-Vee Pharmacy. I've been a pharmacist for 31 years with different companies. The big thing is, with being a pharmacist, I think it's about really helping people. If you don't have like a real good relationship with your pharmacist, I think you're really missing out. A lot of the patients that I serve, I do know them personally, I know what's going on in their lives. When people come in, it's nice to know who they are. They can ask me any questions. If I don't know the answer, I can find out. But the pharmacist, no matter whether it's Hy-Vee or Walgreens or Walmart, they're really a good source of information for you. So, other than that,
Good morning. My name is Beth Berg. I am the local long-term care ombudsman for Polk County. I know ombudsman is a mouthful. So I like to, people say I can't say that word, I don't know what you are. I'm a helper. I'm an advocate. So our office is under the Department of Aging for Health and Human Services. And we advocate for people who live in long-term care facilities, assisted living, residential care facilities, and also folks who are living in the community that receive HCBS waiver services. So if you're on elderly waiver and maybe you experience an issue with the services that are being provided and you're not quite sure who to turn to, you can reach out to our office and we can help advocate through the managed care organization. Reasons that people would reach out to our office, if you're in a long-term care facility and you feel as though maybe your rights aren't being respected, or there's a question with billing or the care being provided, that would be a time to reach out to us. And initially, we're really going to encourage autonomy and self-advocacy, and try to help you work with that facility. And if that doesn't work, by providing resources or just general information, then we can get involved. We always have to have either the resident or the responsible party's permission in order to advocate. And our office is separate from the Department of Inspections, Appeals, and Licensing. It's a different entity. They're regulatory and we're oversight. So, and I've been doing this for about 4 years and cover just Polk County. There's a map back there on the table for the state of Iowa. So if you or someone you know is outside of Polk County and has questions about our office, there's more contact information on that, on the second table there. In the back.
Thank you for those introductions. And we're going to try to give them each about the same amount of time to talk about their area of expertise, but we're gonna start with Kevin. And one of the first questions, and what I've also asked them, is if something in the other two is pertinent and they wanna jump in, they will jump in as well. But we're gonna focus on Kevin's world and Metro Geriatrics. And one of the first questions is just tell us about Metro Geriatrics, maybe what it is that you do, and maybe some of the misconceptions that people don't understand that you don't do.
So we founded Metro Geriatrics with the idea that we were going to take care to the people that need it and not have to have them come to us. And specifically, we serve a lot of small town facilities across Iowa and Nebraska that otherwise wouldn't have any care or very minimal care. Our goal is primarily to provide long-term care at a time. So it used to be a physician at the end of the day, after they saw patients all day, would they come over to the nursing home and see the patients that were there, spend a few minutes, write some orders. And we wanted to make that much more personal, and that's all we do. We don't see patients in facilities or in a clinic. We don't see patients in hospitals. We see folks where they live, and we take care of them. In the assisted living centers, we can provide blood draws. We can bring X-ray in. We can do different things. And again, we work with guys like Jeff to make sure that you're getting the right medications. And that's obviously a process that you go through as you transition to a facility. Metro Geriatrics is, like I said, a group of physicians that are specialized in geriatric medicine. And then all of our nurse practitioners and PAs also are specialized in geriatric medicine as well. And there's different things that occur as we get a little older and the medications we need. Now, we still work and coordinate with specialists. If you need to go see a specialist, then we do that all the time. So that's kind of who we are and what we do.
Many people say that they see one doctor who sends them to another doctor, and it kind of goes down that line. What do you have to say about that?
So, over the course of the past probably 20, 25 years, we've been, the United States has been trying to bring healthcare into one bucket. I don't know if any of you remember or were part of it, that when we started the idea of trying to put all the medical records in one place, and that failed miserably. And within this room are many different organizations that provide healthcare, and none of it's connected, and that remains that way. And you may be part of the Mercy system or part of the EAD point system, but even in those cases, the physician, so when you go see one doctor, the physician over here, another specialist that may be seeing, may never see those records. And that gets very frustrating. One of the things that we do at Metro Geriatrics is that we have a triage team. We have nurses that do nothing but coordinate that care. So our job, when you're in a assisted living or in a long-term care setting, is we're going to try and coordinate with all the specialists to make sure that the cardiologist knows what the orthopedist is doing, right? And it's very complicated at times. There's no one real answer except to say this, that the better you are at knowing your own medical history and the medical care that you've had, the easier it's going to be for the providers. And obviously, if you get to a place where your son or daughter needs to be in that role, making sure, planning, to make sure that they know your history so that they can get that to physicians, specialists when you go out and see them.
I think to even expand on that from when we talked before, prepping for the seminar here today, it was having a one-page document that provides that history.
Yeah, as we all get a little older, we get a little more forgetful. So it's a good time, now, to put together a one-page document that kind of says, hey, I had an appendectomy in 1986. The medical history that you need to impart to a physician or a nurse practitioner. But then a list of all of your current medications, your wishes, your desires, where your living will is at. If you have a power of attorney, who lives in your, one clear, so just having lost my mother and my father in the past year, we had all that put in place. We actually have a laminated page, front page that was laminated that they can take with them to the physicians. And we would update the minutes as things change. Yeah, having that is a good idea. Definitely helpful.
Very good. The next question may be something that can be answered by Jeff as well, but I will ask you this as we talk about this. Some older adults may be taking 6, 10, 15 different medications. And who is responsible for making sure those medications are all going to work together?
Well, I'm glad you asked that question because I think Jeff will appreciate my answer here a lot. I'm going to give you all a little piece of advice. When you decide to move into an assisted living center or independent living, but specifically into an assisted living, if you decide to go that route, please work with that assisted living center and allow them to use their pharmacy for your medications. And I say this because the nurses and the pharmacists that are taking care of those medications coordinate, talk, work together to make sure that you are on the right medications and along with the provider. And when you run into a case where you have multiple medications, lots of different medications, we get inputs from guys like this every day saying, hey, you've got a double type of medication here. You should think about stopping those kind of things. And if you decide to move into assisted living, you just go to say, no, I'm going to keep using the same pharmacist, which I love and appreciate those pharmacists, but at that point, it can get very complicated, and we lose that connectivity that we get from working with a directed pharmacist in those situations. And when and if you go to a long-term care setting, you will only be working with one pharmacy at that point.
If you feel comfortable, would you say you have an opinion on the PCP, whether that's with the community or can that be outside?
So some folks, when they come into a facility, I'll just use Copper Shores for example. Copper Shores, we probably care for half or 2/3 of the patients in that building. And when we started, it was only like 3 or 4. But people realize and understand that we're going to come to you. We're going to be coordinating with the pharmacy and the other providers that are out in the field, and obviously with the nurses in the building. Doctors that are working in healthcare today are locked in a building. I don't mean that literally, but they are, 7 o'clock in the morning till 5 o'clock at night. They're seeing patients one after another after another. And when something happens and you need care, getting a phone call, you call and you leave a message, they will hopefully call you back. When you call Metro Geriatrics, you call a group like ours, a nurse picks up the phone and talks to you and takes care of it in real time. So that's very important, especially because your medications and making sure that we don't have any issues with those. So yeah, having a directed provider that is part of the facility setting has been very helpful. And in fact, with some facilities, with assisted living, when there's memory care groups will say, you need to have Metro Geriatrics or another group be here because it's harder and harder to get out into the community when you're in a care setting.
What is one question you should have every patient ask before they leave an appointment, whether that's you visiting or they're at their own appointment?
So when you're seeing a provider, whether it's in your home, it's one of our folks or one of the other groups that come out, or you're seeing a provider in the doctor's office, please remember to advocate for yourself. And the most important thing I can tell you is that if you don't understand something, you stop that physician or that nurse practitioner and you tell them to explain it to you. I see so many patients, we deal with this all the time, where they've gone and seen a provider and they leave and you ask them, well, what happened, how'd it go? And they can't tell you anything. Right? So if you don't feel comfortable being a provider, you back up. My mom, who just passed away, go to the doctor, she never wanted anybody to go. Well, that poor woman had cancer and we didn't even know. And that's the kind of situation that you want to avoid. So making sure that you understand what your diagnosis is or what the treatment plan is incredibly important.
So understanding is one thing. What if you disagree with the recommendation? What do you have?
So if a physician says to you, hey, you've got this and we want to do X, Y, Z, please know that it's your body and, the old saying, it's my body and I have the right to do what I want. Question everything. Physicians they're just like carpenters, or just they're like everybody else in the world. You get up in the morning, you do the same thing over and over again. You see the same patients, the same kind of problems, and sometimes they can get dialed into one way. I'm not saying it's a bad thing, but they can do the same thing over and over again, and it typically works. But if you question that, you stop them and you say, I don't agree with this. What else can we do? And or can I get another opinion? And advocating for yourself is important. Most of us don't do it, right? Most of us go in, hey doc, how's it going? Stomach hurts. Well, here, let's get an x-ray, let's take a pill. And we walk out and we go, okay, fine. But if you don't agree with what that physician wants to do, and especially if it's concerning major surgery or a major invasive procedure or a major medication that may have lots of side effects, stop and just say no. You don't have to take that. You don't have to take that pill. You don't have to have that surgery. And there's nothing wrong with saying, I don't want to do this. But so often, you're told this is what we're going to do, and we just run off to do it without feeling comfortable or even understanding what's happening.
Is there anything else you would say for preparation in addition to the sheet or the history that's laminated that you mentioned earlier before going into an appointment to maximize what they get out of that?
So this is another funny, but when you're going to see a physician, they have about 10 to 15 minutes to see you max, right? That's all you're getting. In typical cases, be specific about your problem. When you go to a doctor and you say it hurts here, right? They go, you gotta go, hurts here. Yeah, and then maybe at that visit you're only going to focus on that problem. Now, if truly your whole body hurts, you ache, that's a different course. But so often you'll go to an appointment, you'll be like, well, my little toe hurts, my right shoulder hurts, and my left wrist hurts. And a physician can get overwhelmed by that. I worked for an orthopedic surgeon for 6 years, and I used to see this happen. People come in and they just overwhelm me with the problems, and it gets really hard for physicians to treat everything in that 15 minutes. So I guess the way you look at it is you've got a specific medical problem, manage that. But if you've got something that's hurt in multiple spots, try to limit that a little bit so that he can focus on the thing that's happening. The one that hurts the worst, deal with that and then move forward from there.
Thank you. Insurance itself is a whole seminar probably, but if you could just say a few comments about insurance, what would that be?
Well, again, we could all probably talk about insurance. I want to tell you something, and some of you may not like this, but I'm going to tell you anyway. The Advantage Care Plans Probably a lot of you are on them, all right? They're cheaper, less expensive. I just want you to remember something. And this comes from 35, almost 40 years in the healthcare industry. Insurance companies make money two ways. How do they make it? They make it by denying care or limiting care. That's just the bottom line. That's what insurance, that's why we get the big principal building downtown. We don't get that because they're losing money. Direct, straight Medicare does not have the limitations that the Advantage Health plans have. So here's what I'm going to say. Some of you disagree with me, I don't care. If you're otherwise healthy, be on an Advantage plan. If you have medical issues, do straight Medicare. And that's my personal opinion, but I can tell you that I see it over and over and over again, where you fall and you break a hip. And if you have Medicare, direct Medicare, you can go to a facility, a skilled facility, and you can stay for 2 weeks. You have Humana, you're out 3 days. They're not going to pay for any more than that. And why that matters, and again, great companies, I understand, and they're there for a reason, but we get calls every day from families going, what do you mean they're kicking my mom out of this facility? And it's not us doing it, it's the insurance companies. The insurance companies say, well, you're good enough, we're not going to pay anymore. And I just want you to, again, it's my 2 cents, but if you're super healthy, Advantage plans all the way. But if you have any inherent medical problems, and a lot of us do, it's something to consider. So there, I said it.
Thank you. Beth has something to add there.
Just want to add that, obviously, or probably not obviously, which I can't tell you what to do or what decision to make with regards to the Medicare or the Medicare Advantage. But for example, kind of like what you said, if you're in a facility after you've fallen and broken it, you have traditional Medicare, you have a certain number of days, therapy is going to provide updates, you're probably going to be there for an extended amount of time, or the amount of time that you need. With the Advantage plan, it could be just after a few days when updates are submitted and then the insurance company comes back and says, okay, this person's ready to go home. Now, you have the right to appeal that. There are appeal rights. What I would say right now in the moment, if you have questions about your own Medicare policy or Advantage policy, you can reach out to SHIP, it's SHIIP, and they can answer those questions for you and be helpful. So I know we have a limited amount of time here today to talk about things, and insurance in and of itself could be an entire seminar, but there are resources available, and that's one thing too with our office. If you reach out, if I'm not the person who can help you, I can point you in the right direction. My friend for Aging Resources is here today. They're also a wonderful resource for folks that are still living out in the community. So I just wanted to add that.
I think you can probably get a lot of calls with being exited out of the facilities pretty quickly.
Yeah, I get a lot of calls from folks. They're kicking me out. I've only been here 3 days. And they're upset with the facility, but it's not necessarily the facility. The facility has, either they have their own in-house therapy or they contracted therapy. Those therapists are doing their documentation and they're submitting it to insurance. So it's not always the fault of the facility, but just be aware that you do have appeal rights in those situations, and we can walk you through that. I can walk you through that. The facility should be able to walk you through that as well.
Yeah, and SHIP is the place to go. They can give you good answers. I want you to rely on me. I've seen this so much over the years. It's so frustrating to see what happens. It's just my little 2 cents. So I hope you understand that.
Feel free to jot down your questions and we'll take questions at the Q&A. And we will give Kevin the last opportunity before we go to Jeff. What is it that you would like to leave with everyone?
You know, the last thing I'll say is we're all going to grow old, and we're all going to die. And how we do that It's up to you. It really, you play the major role in making those decisions, right? Have a good living will. Talk to your family. So many of us avoid the questions that we need to be talking about. And understanding those things will make a huge difference in how the last chapter of your life goes. The average person spends 2.1 years in a nursing home. So that's kind of the long and short of it. Now, in assisted living, it's a little different, but make those years good and productive, and you do that by planning. So, there you go.
Thank you, Kevin. It's a good segue into pharmacy. We will have Jeff. How about providing us, one of the first comments is, bodies change, just like Kevin has said in the last chapter of one's life. What are some of those warning signs that one should be looking for, and especially if they're getting new medications and how to deal with that?
Well, when you get a new medication, you're older, drugs are always metabolized. And so are your kidneys working properly? Is your liver working properly? When you're getting new medications, pharmacists should be reviewing all that. Are you the medication you're getting is going to make you subject to falling? Again, every medication that comes through, the pharmacist usually does a drug utilization review. Are there drug interactions? Is it the correct dose? Are there drug overlaps? Are you seeing 2 or 3 different doctors? One doctor is prescribing one blood pressure medication, another doctor is prescribing another one. Are they overlapping? Do they interact? That's the thing you look out for. And the main thing is, when you pick up a prescription at the pharmacy, the pharmacist is supposed to counsel you. Or, let's say Jane Doe comes in, there's prescriptions that came through. One doctor might not know the other doctor is prescribing a medication. So we'll go on the phone and say, hey, do you know that Jane Smith is getting this? I did not know that. So cancel this medication or go from there.
One of the comments in the prep, you had said that you have a system. Can you talk about that system and how that catches or detects some of those interactions?
Right, so it used to be, you really have to be on your toes. They used to have this book, and it was called Facts and Comparisons. If you thought there was a drug interaction, you had to actually go through the book. Now everything is computer generated. So as we're running your prescription through, we're getting contraindications. Number one, is it serious? Let's say they're giving you penicillin, you're allergic to penicillin, that's going to pop up. A lot of the drug interactions are screened by the computer also. So it really helps us.
So what's the next step if there is an interaction? Do you contact the physician?
Definitely contact the physician, talk to them about that. Sometimes there's a drug interaction, it might not be severe. We'll call the doctor, and the doctor is like, yes, I'm aware of that. Let's just go ahead and go with that. For example, if you're on, let's say, a blood thinner, let's say you're on Coumadin, and they give you an antibiotic, but the antibiotic is short term, 3 to 5 days, you might not have an interaction or cause increased bleeding. So the doctor's like, I'm aware of it, let's just go with this.
Polypharmacy is kind of a new buzzword. What can you add to that, and how can pharmacists help with that?
Yeah, if you're going to like 2 or 3 different pharmacies, sometimes that's not the best thing to do, because one pharmacy won't be able to tell what another pharmacy is filling, unless it's a duplicate fill. Let's say you come in for blood pressure medication and I'm trying to run it through, and let's say Medicap is running the same thing through. I'll get a rejection from the insurance company. It'll say, this was just filled on 8/15 for quantity of 90 templates. So yeah. And where it really comes into play too is we have a lot of people that are controlled drug seekers. They want Vicodin, they want hydromorphone, they want things like that. There's a thing in the state of Iowa, it's called the PMP. I can see all the controlled substances that are filled in the state of Iowa. On a chronological basis. So if this person got 120 Vicodin at a Walgreens, and then they're coming to me to get another 60 from a different doctor, I can see that and I just call the doctor, and they're usually canceling.
Okay, thank you. Most people think of pharmacists as filling the prescriptions, but I believe you could also be considered a consultant as well. You don't have to be at the time of filling a prescription to utilize your services to ask, whether it's like an advocate, if it's a child assisting with a parent, just to call and ask those questions. Is that correct?
Yeah, I mean, pharmacist is there, and we don't charge you anything. People come in all the time and like, hey, I got this rash, what can I put on this rash? Here's a problem. Direct you to whatever we think you should use. If that doesn't work within 3 to 5 days, then we'll say, maybe you'll seek a physician. Or somebody will come in and will like, hey, I think I need a shingle shot. And I can look that up on the state of Iowa website, and I'll say, you don't need a shingle shot, you've already had 2. So, but some people just forget, you know, well, I did have shingle shots 2 or 3 years ago. So, yeah.
What is one of the biggest mistakes that people make in medications?
Not really knowing what they're for, and
And possibly when they started it and they're still taking it?
right. Or if you're taking it, the doctor can tell you to discontinue it. That would be the biggest thing. Another thing is, when we talk about healthcare and insurance, make sure you know your deductibles before you go to the pharmacy. I see so many people come in, copay might be $75 for one med, and they're like, $75? Why shouldn't I have to pay anything? Get on the phone, oh, your insurance company, yes, you have a deductible to meet.
If an older adult or family member wanted to have a medication checkup, do you do that in the pharmacy?
Yeah, I mean, if we're not busy, or you can schedule an appointment, just bring the list of medications in that you want us to review, and we can review those predicts.
And then how does that look? Are you working with family, or are you checking with the PCP and if something was contradictory?
We like to have people, well, usually it's people that go to our pharmacy to do that, but we'll just run down what's wrong, what it's used for.
If everyone in the room just remembered one thing about a pharmacy or a pharmacist, what words of advice would you give?
Go to a pharmacy and a pharmacist that you really trust. And they get a good report.
Okay, is there anything else you would like to add before we move on to that?
I think that's really about it.
Okay. Well, that word is our ombudsman, and like she said, it is a mouthful, and we'll just call it a helper. But I think first, what we may just want to set the stage is, you see that term, you see it in hospitals, you see it in communities, and in long-term care settings. And so, if you can describe each of those, and that you are the local long-term care for Polk County, and then just kind of add how that's different from a hospital setting.
So, sometimes we get calls from the hospital, from either a social worker at the hospital or someone who's a patient, and they have concerns about the way that they're being treated at the hospital. So that would not fall under our purview. That would go back to the hospital or to the Department of Inspections, Appeals, and Licensing. They're the regulatory agency that oversees the hospitals. And then there's also, just to add confusion to the mix, there's also a state of Iowa ombudsman, which is a separate entity from ours, and they investigate complaints about other state agencies. So a lot of times people just look up ombudsman, it takes them to that website. They call them with a complaint about a nursing facility or an assisted living, and then they turn around and send that referral over to us. And then our office, if you're out maybe visiting somebody in a long-term care facility, a nursing facility, or an assisted living, you should see a poster on the wall, someplace that's very visible, either at the entry or maybe where you see a menu or activities calendar posted, and it should have contact information for our office in the event that someone there needs advocacy.
Could you give an example of the state ombudsman? What would be a situation or example there?
So if you had a complaint about, if you had a complaint about that, about the Department of Inspections, Appeals, and Licensing, or another state entity, maybe that you have experience with and you weren't pleased with the outcome, or you weren't getting a response, or not pleased with the way that you were treated, that's when you reach out to them.
What is one of the most common concerns or complaints that you receive?
I would say most common are resident rights, so dignity and respect, the way that someone is being treated or talked to by staff. Staffing is always a concern. There aren't enough people here to take care of us. I waited 2 hours on my call light, so response time and staffing. Food, we get a lot of food complaints. You're going into a facility. It's not, most facilities, it's not gonna be like a home cooked meal or how any of us would prepare it at home. My mom, she was a huge liver and onions person. Gross, right? I can smell it. I would pull in the driveway and I could smell it and I would leave. When I go to my friend's house, I would call and say, you let me know when that's all cleaned up, and then I'll come in. But for example, just very, sometimes when we live in our own home, we make our own food, we're very particular about how it's prepared. And then we move into a facility and it's not seasoned the way that we like to have it seasoned, or everything is dry and we like a rare burger. Sometimes you can, depending on where you go, sometimes you can go and you can order things very specifically or tailored to the way that you want it done, but a lot of times that's just not an option. So that's a complaint that we get a lot, and it's something that we try to work through with residents, tenants, and with the facility too. Like, have you, if I go in and I talk to a dietary manager or an administrator and they haven't sat down and had a meal in their facility, that's a problem. Because how can you sit here and tell me we do the best that we can do, the food's delicious, it's wonderful. Have you had a meal? Well, no. Okay. So that might be a suggestion that I might make to someone in a facility, like somebody that works for a facility, is put yourself in the resident or the tenant's shoes. And just real quick, I just wanted to touch on something that Kevin had said about when you move into an assisted living and choosing a physician or choosing pharmacy. And I used to work on the facility side, so I get it. And I can kind of play devil's advocate a little bit, because as far as continuity of care, it's wonderful to use that physician and that pharmacy. On the flip side, in my role now, where I'm advocating for a resident or a tenant specifically for what it is that they want, and looking at it from your perspective, you're leaving your home, you're leaving everything that you've done, you're losing your sense of autonomy. Maybe you have a really great relationship with your pharmacist or your physician, and that's the last thing that you want to hold on to before you let everything else go. It is your right to have a say in your healthcare. Again, double-edged sword. For continuity of care, absolutely, because you want everybody on the team to be speaking the same language, but sometimes it's hard to let go of those things, and it's your right to hold on just a little bit longer.
if you're willing to share, do you see any negatives of having that continuity under the same community?
What I see, especially on the assisted living side, I see a lot of turnover with the leadership, one, and then also with the pharmacies that they contract with, which isn't always the fault of the leadership in the facility. Sometimes that's the management company ownership. I would just say, pay attention when you're touring these places and you're having these conversations. Those initial conversations are really exciting because I might be moving into this beautiful building and they have all of these amenities. But ask the questions. What pharmacy do you contract with? Can I continue to use my own pharmacy? What does that look like? And some people, when they move into an assisted living, you might still be able to manage your own medications. And again, hold on to that sense of autonomy and independence and do that for as long as you can. We always encourage folks, I think any of us up here would encourage you to age in place for as long as you can, stay in your homes for as long as you can, and use the resources available to you.
Thank you. So now the process, let's kind of talk through how that looks. You're also a consultant as well, or your office, where if people are contemplating going into a community, I learned that during our conversation in the prep work, that you can answer some of those questions. You're not guiding them or steering one direction or away, but it's more of asking the right questions of going into a community. So kind of talk about that. The first step is just asking and gathering information first. And then you can lead into if there's actually something that someone has a complaint about. Right.
So if you're reaching out and you have a question about a specific facility, like, I'm looking at Deerfield, do you think I should go there? I can't tell you that. I can say, well, you could look up CMS, Care Compare, and you could see what their star rating is. You could see if there's maybe some Google reviews out there. You could look at the Department of Inspections Appeals of Licensing Health Facility Database. And you could see what their most recent surveys look like, because that's public information. So those are the resources that I would provide. I can't tell you. These are the top 3 facilities that I visit, and you should definitely try to get in here. I would love to be able to say that, but I can't.
So if someone has concerns about their loved one on the actual care, they may know and have seen the sign, hanging in the community, and they give you that call. What is your next step?
Sure. So it's always your right, your loved one's right to reach out to our office to file a complaint with us or with the Department of Inspections, Appeals and Licensing, or to file what's called agreements at the facility. So if somebody reaches out to me initially and they say, Mom is in this building and they don't answer the call light, they don't change your brief, food is cold all the time, my first question is your mom able to make her own decisions? And does your mom have these same concerns? Because my role is to advocate for what the resident wants. And sometimes that might differ from what their family member wants. It's hard for us to go in as a family member and see maybe some things that are going on in the facility and right away want to jump on a call and make that complaint. But let's talk to the person who it actually affects and find out if that is a concern that they have as well. If it is, then my next question would be, okay, have you talked to someone at the facility about this? Is there someone you feel comfortable having that conversation with? Whether or not it is the administrator, an executive director, a director of nursing, a social worker. I would encourage you to build that relationship so that you feel comfortable having those conversations. So if the answer to that question is no, I'm going to study the continuum at the facility. Okay, well, how do they know that there's a problem and how do they work towards fixing it if you haven't had that conversation? So sometimes our conversation might end there, and they might say, that's a good idea, I'm gonna go, I will talk to this person, I'll work on a resolution, and I'll call you if I need your help. And then they take it from there. And then if they're not pleased with the resolution, then that's what I would say, give me a call back. I would need either the resident themselves or their responsible party, who would be like a power of attorney, to give me permission in order to proceed to advocate on their behalf. And that could look like making a phone call to the facility, sending an email, or making a visit.
So it may be worth repeating, you already didn't say this, but the difference between your office and Dial, which is Department of Inspections and Appeals, and your office is more of a mediator, is that correct?
We provide oversight, so I don't like to say mediator, sometimes I like to say conduit, you know? We can help to make that connection with the facility because ultimately that's the person's home. And the hope would be that they do feel comfortable having those conversations. And, you know, we can make suggestions. I can't tell the facility, you have to do this before this date. But I'm gonna make suggestions and I'm gonna ask them to follow up with me and to follow up with the resident. We can investigate complaints. We can help set up like a resident or a tenant council. We can offer education. Dial, the Department of Inspections, Appeals, and Licensing, they're the regulatory agency. So they come in at least annually, if not more. If there are complaints throughout the year, you're gonna see them more frequently in the building. And they're really digging into records, into the environment, into the kitchen. So they're a separate entity from us.
Another thing you might want to add is what rights do families and residents have? And under that question, asking about occupancy, service agreements, and that type of thing before actually signing the documents going into a community.
Right, so if I haven't already made it clear, you have the right to file a grievance or make a complaint, right? You have the right to participate in your plan of care. You have the right to receive copies of your medical records. You have the right to dignity and respect. The right to be free from harm. Lisa and I had talked about, you know, she might have had some questions about services that are provided maybe on the assisted living side. And I said it's really important, again, ask questions, but also when you're going through an occupancy agreement, whether that's when you're going into assisted living or if you're signing an admission agreement in long-term care, go through that thoroughly. On the day of move-in, things move fast. You know, you're coming from your home, you just want to get settled in, you just want it to be over with. And it's really important that you read those thoroughly, especially in assisted living, because it's regulated differently than long-term care. And oftentimes, if someone has a complaint about billing for an ancillary charge, there's really not a lot that our office can do if it is already listed in the occupancy agreement. So I'll always, that's kind of a first question when someone calls and complains about an extra fee. I'll say, okay, have you reviewed your occupancy agreement? No, it's 70 pages long. Well, let's go through that and then call me back. And if it's not in the occupancy agreement, then I'll do what I can to help you. But if it's in the occupancy agreement, it's gonna be tough to get out of that.
what advice do you have for families to take away today? And if there's anything else that you would like to cover in the last couple minutes, feel free to add that as well, Beth.
Sure. I think we've all maybe touched a little bit on substitute decision maker or a power of attorney. And I would just reiterate to be sure that you have those documents ready to go, that you have a power of attorney, that you've made your wishes known. Also, a power of attorney, just because you complete that document, doesn't mean that that person is able to make decisions for you from the moment that you sign that. Look at the verbiage in the power of attorney paperwork. Does it say this power of attorney goes into effect the date that it's signed? Or does it say this power of attorney goes into effect when my physician deems that I'm able to make my own decisions? And really that comes in more to play, unfortunately, when it's a little bit too late. Or on the front end of things where a power of attorney says, I'm a power of attorney. I have paperwork right here, I can make decisions. Okay, is there a physician statement on file that says that your loved one can't make their own decisions? Why do I need that? I have power of attorney paperwork. Yep, except it says that it's not active until a physician says that they can't make their own decisions. So I get a lot of calls from folks that are really frustrated because the facility continues to defer to the resident, which they should, or to a tenant, and people get really upset about that. So I would just really encourage you to pay attention to that, and again, to ensure that that's something that you have set up. And we talked about partner conversations. We don't want to talk about death. It's not fun, it's not glamorous, it's not pretty, but we have to have those conversations about what we want the end of our life to look like, and we have to be able to share that with whomever we are giving that power to make those decisions. Because we don't have those conversations, and it comes down to maybe looking into hospice or having to make a hard decision in the hospital. Our loved one might find it really hard to do what it is we want to have done. So it's, again, just, I would really encourage folks to have those conversations. And when you're looking at, maybe making that move into a facility, ask a lot of questions, reach out to me if you have questions. What should I look for? What questions should I be asking? I had a friend of a friend who lived here and this happened to them, and is this right? I can answer those questions for you. I would also tell you, if you're considering making a move at any point, visit. Go in, take a look around, talk to other people who live there, look at the menu. What kind of food are they serving here? Look at the activity calendar. What goes on here? And are there activities in the evening? Are there activities on the weekends? Or is it just Monday through Friday? Maybe we have bingo one day, we have an entertainer come in another day, and we have pet therapy. How do you want to age? What things are important to you? And ask those questions and have those conversations. This is what's important to me. This is what I want the next 5 years to look like, and can this community offer that? And if not, then
Thank you, Dad.
Just want to add a couple of things to that with the power of attorney. The fastest way to watch your children fight is not having one. And we get all the time at Metro Geriatrics, we get them in our office, son and daughter, screaming at each other because what are we going to do wrong? So your living will and your power of attorney are two of the most important documents that you can create and make sure that you have. And to her point, to Beth's point, we commonly, you have a power of attorney, but we don't know it, nobody tells us. So making sure that your provider knows and that the facility knows. Because we get called all the time, and we don't have a power of attorney. we can't talk to that person. And part of that too is, I think the last thing I'll say about that is making sure that we're aware and the facility is aware that who you want us to talk to, right? That if it's more than one person, you may have one power of attorney, but you may want us to talk to both your son and your daughter, or both your daughter. Make sure that we know that. That is very helpful. And we'll ask, but if we don't get it from you, we won't do it. So good point.
Do either of you, any of you have any last comments before we get the mic runners to start walking up here and the Q&A? Any last thoughts? So with that, we will open it up for Q&A.
First of all, from the way you were talking, I understood that Medicare is different for each individual. I did think that was true. Yeah, I know Medicare Advantage, but Medicare is the same Medicare for everybody, same thing. That's what I thought, but I heard it a little differently. And then what do we do with providers that when they give you medicine, they use the fear factor on you? I don't want to take this, but if you don't, honey, you're going to have a stroke, and you don't want to live with a stroke. I think we all hear that because we're old. So how do we combat that with our pharmacists when we say, we're not really sure this is the best medicine, can we get this as the equivalent to? Does that make sense? Like, let's go Eliquis with Coumadin. I don't know, something. I'm not a pharmacist, so.
Trying to think what your
My
question.
question is, the doctors always say you must take this because it's the best. If you take this, you're probably going to stroke, even though they're both blood thinners.
Right.
And for us, it's a fair factor.
It is a fear factor. I think they would know better than the pharmacist. A lot of times when we're talking about things like that, I see a lot of diabetic medications. One of the diabetic medications is Jardiance. Everybody that comes in to get Jardiance, it's like $300 some dollars. Hey, nobody's gonna spend $300 a month on a medication. So we'll just call the doctor's office and say, hey, can we use something else that's gonna do the same thing? It's not gonna cost this person $300 a month. But as far as the fear factor thing, that's a good question. You know, if that's what the doctor wants, that's pretty much strong. Dispense.
I understand that, but I think that because they're educated
Right.
and we know our bodies and we function, okay, Eliquis is very, very high
Yeah.
in price. And it's, I don't want to throw out things, but I just looked it up and it's $18 per person per year to make Eliquis.
Right.
So look at what we are charged.
Right.
So is there something comparable or
Well,
I really say this, you didn't pick that?
Eliquis, before these drugs like Eliquis came out, everybody was on Coumadin. Even myself, I was on Coumadin at one point in time because I broke my foot. It's like, it's a pain to go in and have your INR checked every week. Adjustment every week. It's just so much easier to just do the Eliquis and just be on your way. I think personally, if I had an incident like that, or I broke my foot, or I was on the clock, I just take the Eliquis.
Elaborate again of what that care compare was. I wasn't sure what CMS was. Didn't want to look up other facilities.
So CMS is the Center for Medicare. So you can look up you do like a Google search and just type in CMS care compare. And you can do that for nursing facilities. You can't do that for assisted living. And I just want to add one thing about questions to ask when you're going into a continuum of care, like you talked about. I can start here and I can age in place, right? Or when you're going to an assisted living, If it is all a concern that you might run out of your financial resources and eventually apply for Medicaid, make sure you're asking that question. Do you accept Medicaid? Am I going to be able to stay here? If they tell you yes, get it in writing. Because if it's not in the occupancy agreement,
Yeah.
right, yeah.
It's a big question that.
Just a quick question for Jeff. I'm not on many medications, this is one, and I've been on it forever. So maybe I don't remember, but how does my pharmacist know what my allergies are? Does the doctor tell
Well,
them?
in the computer system, it will flag it. If you came in to fill a prescription and you didn't have any allergies on file, the computer will automatically flag it and say no allergies. So I can put no allergy warning. So we may fill a prescription, but on the monograph, we're going to give you right up front of it, like, what are your allergies? That way we can update that in the system. But that's not something that comes usually from the physician. You know, if we're filling like an antibiotic or something like that, and there's no allergies on file, or maybe there's a cross allergy, we just call. But yeah, usually we'll ask you about the appointment that we can get.
I just have a quick question for Kevin. How do your company pay?
But you send us a check. No, we're paying, we're paying 99% through Medicare, Medicaid, right? And so, good point. Everybody in Medicare has deductions every year, right? It's going up, picking up a little bit. Because we always get calls in February going, why am I getting a bill? And then you'll get a bill after that, you'll get that bill. And that's your deductible. And, but yeah, we Metro Geriatrics will bill for those deductibles, but then typically you don't see another bill from us. You'll get EOBs and things from Medicare, obviously, or they cut, okay, yeah, it's all, we have maybe 5 patients out of 8,000 that are private pay. So.
Here's a real quick question. My wife was up here and I said that I needed to have police last year. We have a friend that's an attorney that made a good suggestion. I thought I'd pass it on. He said, in case of your living will, in your power of attorney, stick a copy in your glove box in your car. When we travel and we have accidents, someone alluded to one earlier this morning, it's nice to have that available to you. You never know what you might need there. So make sure your hospital has it. I don't know how to do such pretty good, but to make sure they got it, the doctor's got it, stick it in your car as well. So when you're traveling, etc.
I feel Iowa needs facilities to help a person end their life on the day they choose to give the next.
Wow. So what she said is that, and this is you hit it home, Jeff, because my mom is that. Well, I just went through this. She said that she thinks that facilities should allow patients to die on the day they choose, the way they choose. That is a conversation we have all the time in Metro Geriatrics. And, you know, euthanasia, that's what it is a very tough question. Some states allow, but you don't allow it here in Iowa. So I'm sure Beth probably has some thoughts on this.
Well, I guess I have my watched my mom passed away from cancer. So in Speaking from a personal perspective, I wish that that would have been an option that she would have had. Speaking from a professional perspective, plead the fifth. But that could be something that is coming our way. If you find yourself in a situation where you do have a terminal illness, I would encourage you to have a conversation with your physician about hospice and what options they can provide. Because you can receive hospice services in your home if that's where you choose to be. And that's not necessarily, that's not going to allow you necessarily to choose to leave in the time, right?
Yeah, just one point about hospice. We use hospice a lot. Go back here, we use hospice all the time, and we work with them all the time. And my mother thought the day I talked about hospice, well, you just want me to die. And let me tell you, hospice is not there to kill you. It's there to help you die with dignity. And more importantly, you can start hospice. You can be on hospice for 6 months and even longer. Don't be afraid of it. When your family or your doctor says to you, hey, it's time to look at hospice, do not be afraid of that. Use it. It is there. My mom, when she finally accepted that, she was so happy. She had her first big bath. I've done it. But it just happened. So, but let me tell you that hospice is a valuable piece of our lives that we should use.
What is durable power of attorney? That was when we talked about that. Does that help?
Durable power of attorney, and I'm not an attorney, but that basically says, and it's durable because it lasts. They can't, you can't take that back. It's something that lasts until you die. But that durable power of attorney says that she now makes your decisions for you. That's what it means. That they decide whether you get medications, whether you don't get medications, whether you fall and break your hip. We're not going to fix it because she's dying. And there comes a point in people's lives where not everybody, or some cannot make the decision for themselves, and that's what durable power of attorney is. Along with that is a living will that basically says, I don't want CPR, I don't want to be intubated. That's a big one. Not being intubated is a big one. So, but that's what basic understanding of what durable power of attorney is. That's somebody else to make that decision.
I just wanted to comment the gentleman in the front about my chart. He said years ago, the same app also works for Trinity Health, which is Mercy One.
Yeah.
So you have both right there in one app. I just want to share that.
You talked about power of attorney. Can you explain the difference between power of health care, POH versus a POA?
I'm not an attorney. But basically that allows you to still have the rights to make your financial decisions, but they're making the medical decisions for you. And again, it just depends on where you're at in your life, whether you have the ability to make the decisions yourself. And sadly, like we talked about, sometimes the physician has to say, because if your loved one doesn't want to give it up, you have to have a physician do an evaluation and say, she cannot make her own decision. And then there's legal documents that are followed. We can't go every day to the state. So, yeah, that's the main thing.
Well, let's give these great speakers. And you depart, and they will be